Hello everybody. Today we are going to learn about PCNL. This is the operation for removing the kidney stone or the upper uretary stones. From this picture we can see the doctor can from this artificial channel, the doctor can see the inside of the kidney, so do some other operation. Okay, I'm going to introduce this PCNL operation from these three aspects. The first one is anatomy, also very important. Second one is preoperative preparation. Then the clinical problems and the solutions, surgical process, complications, CT image analysis. For anatomy, we have to know about the other organs. We call it adjacent relationship of kidneys, just the organs or tissues around the kidneys. For the right kidney, there is a liver, adrenal gland. You can see here is the liver, adrenal gland, this one, then both right and the left upper pole of the kidneys, and the pancreatic head here, the duodenum and the ascending colon here, ascending colon. Or for the left kidney, there is a spleen and descending colon, then adrenal gland, also tail of the pancreas. Okay, and then here is the diaphragm. Above the diaphragm, there is a pleural cavity here. So during the PCNL operation, this kind of structure we have to know where is the correct location, so on. So this part is very important for the urologist. And then from this picture also we can see other structures, like from back view, there is a ribs. Yes, the 11th and the 12th ribs. Okay. And then right kidney a little bit lower than left kidney. From back we can see there is a liver. Okay, because of there is a liver, the right kidney location a little bit lower, maybe 2 to 3 centimeter lower. Okay, in adults, each kidney is 10 to 12 centimeter long, 5 to 7.5 centimeters wide, and 22.5 to 3 centimeters thick. Okay. And from this 3D reconstruction, we can see the vessels and collecting system. This is the for this kidney we can see two arteries. Here is the artery, there is artery. Normally one kidney has one artery, but sometimes this kind of mutation we can see. And then for this kidney also we can see the kidney pelvis is a little bit large, extended, because of there is a stenosis, or we can say the narrow ureter or junction. That's we can see this part is the renal hilus. There is some problem, so the urine can't go out. So there's the pelvis is the renal pelvis is extended, and this is the other 3D construction. And from this picture we can see the renal collecting system like this. The calyces and the pelvis. This is the ureter. Okay, there is a stone, just the renal located the renal helix. We call this place renal renal helix. And then from this picture also we can see the renal inner structure, like this is the minor calyx of the kidney, and then this is also the minor calyx, and they are together. This called major calyx of the kidney, and then this is the renal pelvis. Okay. Okay. After we learn about the anatomy of the kidney, we are going to know about we are going to learn about the preparation of the PCNL. At first, for the patients, we have to take some written laboratory workups like blood test, urine test, something like that. And all patients with the clinical or historical or the laboratory signs of urinary infection, we have to control first. Then arrange the operation, and the blood pressure or the blood sugar should be controlled well before the operation. Yeah, the imaging for the PCNL in clinical practice, the doctor takes like ultrasound, QB or IVP, IVU, or the CT scan exams for the patients. But CT scan is the golden start for the diagnosis, and the others can also give other information of the patients, like renal function, the ureter conditions, something like that, or the stone size, location, something like that. Okay, so for the fusion mode, we have to get the DICOM data before the surgery. It's very important. Okay, and then in the indications for the PCNL operation, there is some kind of situation. There are some kind of indications we have to take this PCNL operation. The first one is internal interrenal stones more than 2 centimeter, or the lower pole stones more than 1 centimeter. Then ESWL, ureteroscopic procedure failures, we can also consider the PCNL. Okay, the second is stenosis. It means the upper or the junction of the ureter, because there is stenosis, there is very narrow or small, and then the ureteroscopic surgery, the ureteroscope can't go through this narrow part. So in this situation, we have to take the PCNL. Okay, and the foreign bodies in the renal pelvis or ureter, it means there's another part, some partials like some equipment fragments or the consumable fragments in the pelvis or ureter, we have to remove them by doing PCNL. And the contraindications. Also, we have mentioned before the infection. It's have to be should be controlled before the surgery. So if the patient has an acute urinary infection, we have to control them before the surgery. Okay, so the acute urinary infection, we cannot do the immediate PCNL operation. The pregnancy also, and then inability to tolerate the operative position like this. This PCNL not very appropriate for the patients, and the coagulation disorders. If there is some bleeding issues, we have to solve this problem before the surgery. Appropriate conservations and anesthesia. For the PCNL, mostly in clinic practice, we take the general anesthesia. So before the surgery, we have to tell the patient and their relatives, their family, about the anesthesia, about the surgery, and we have to get their approval and then prepare for the anesthesia. For the general anesthesia, the doctor should do the endotracheal intubation, and then this tube, in clinically they are average type and then enhanced type, two different type of tube, and this type appropriate for the prone position PCNL, but the supine position, it's you can also use this average type tube. Also, it's also good, so it's okay. And then for the position, in China, mostly most doctors take the prone position because the prone position for the doctors, it's convenient to the lithotripsy procedure and the broader, larger surface area, and provides access to most of the calyces. Okay, this different kind of prone position, like just spread legs or some other prone positions. And the supine position, and recently some doctors are going to use this supine position because they believe that this position should be less impact on cardiovascular function, the lower renal pelvis pressure. If the renal pelvis pressure is higher after the surgery, there are a lot of complications, like mostly is the infection. So this is why some doctors choose this supine position. And easy to combine antegrade and the retrograde approach. During the one surgery, the doctor also can use the RIRS, do the antegrade mode and the retrograde mode, and the other doctor do the PCNL from kidney, and remove the stone as much as possible, and then shorter operating time, because choose this supine position, they not need to turn over the patient after the intubation, after the catheterization. Okay, so in clinic we can see the like B position, like this one, modified Valdivia position, and then the G, like this position. I have seen like this kind of position in China. And then hydronephrosis is also a very important step for the PCNL. So before the renal puncture, the patient take this lithotomy position, like this, this lateral view and the front view of the lithotomy position. Okay, first the patient take the lithotomy position, and the doctors use the cystoscope or uroscope to find the urine from the bladder. They find the ureter, and then insert this catheter to the ureter. The tip of the catheter must reach to the pelvis of the kidney, and then they fix the catheter, and then turn over the patient to take the prone position. If the PCNL, they are going to prone position, or they are to the supine position, they no need to turn over the patient, and then irrigate or filling saline water before puncture. If the pelvis, if the hydronephrosis is successful, we can see under the ultrasound, we can see the renal pelvis, even the calyx, you can see very clearly. Okay. And clinical problems and the solutions. In clinical practice, at first, imaging, different imaging modality can give the doctor different information. Ultrasound is only the real-time device, but the resolution is not very high. But CT is a high resolution, but there is a radiation also. It's very sensitive for bone or stone diagnosis, bone disease diagnosis or stone diagnosis. And MRI for very helpful for the soft tissue disease. And then PET-CT and the PET for the tumor diagnosis. So we just take the multimodal fusion system. We invented the multimodal fusion system based on real-time ultrasound combined with the other imaging techniques, provides very clear anatomy for the doctors. Okay, and then the second clinical problem is intraoperative target localization. If the doctor uses the ultrasound, the doctor should be very experienced, and or it's very hard to locate the target place. Okay, it's very hard to locate the target. And for the DSA, some doctor maybe choose the DSA technique. Then there's a radiation. There is not not healthy for the doctor's health. Okay, so for so we use our fusion mode, and then we can also there's a AI technique. Then we can aim the target place very precisely. So also we can navigate precisely. Our device can give the doctor precise navigation and no radiation during the procedure. Okay. And then the third part is the puncture for the PCNL. This is the very, very important and the most difficult part for doctors. Sometimes they might mispenetrate some vessels, okay? So sometimes they lead other unnecessary injuries, perineal tissues, organs, something like that, okay? So we use some high technique tracking system during the operation. We know we can check the needle tip. We know the real-time needle tip tracking. We know where is the needle, what is the depth of the needle, and then also on 3D we also know the probe and the needle and the other organs relationship. Also from the 2D real-time ultrasound we can see very clearly past the target. All the process, all the needle is we can see very clearly. We can successfully avoid some kind of this puncture related complications. Okay, surgical process. How do we do this puncture? Before the surgery, the doctor use ultrasound just to check to see the kidney and then the target calyx before the surgery. And then for the puncture, there is a two methods. Mostly doctors use to in-plane puncture, and some doctors also choose the out-plane puncture. And from this picture we can see in-plane, it means from the two sides of the probe to puncture. In this way we can see the needle the whole time entirely. We can see the needle from the beginning to the reach of the calyx. But the outplane puncture, there is some blind areas. So if we use our technique or magnetic tracking system, even though there are some blind areas, we can track the needle. We know about real depth of the needle. Where is the needle? The depth of the needle, we can see very clearly on our screen. So it's so if we use our fusion electromagnetic tracking system, fusion mode, what kind of method the doctor choose, they're both very, very safe. Okay, and then locate the target calyx. There are some rules for the safety of the puncture. The first is we have to choose mostly the middle calyx. the dorsal medial calyx. Also, the some doctor says the posterior, the backside, the middle calyx, this one. And then we have the aim, the fornix. This place we call the fornix. This place. So like this, the middle of the fornix here. And then choose the shortest axis between the skin and the calyx, like this, the shortest one, and the direction parallel to the major axis of the neck. It means this is the neck, like this picture. This is the neck of the calyx. For this is the needle parallel to the neck, and this is not. So this is wrong. This direction is wrong. This is the correct puncture direction. And then and feelings, like during the puncture, the doctor maybe can feel the sudden emptiness. The puncture go, sudden emptiness. There's water. So if the doctor feels this emptiness, it means the needle already reached the target calyx. Or if there is a stone, like this, there is a stone, the needle, the doctor can feel the stone resistance. So it's some kind of puncture related rules. Okay, and then for the excess size, clinically there are a lot of diameters, shaft diameters. In clinical practice, the 18F is used, very common in China. Some other, but different doctor. This is just because of the doctor's skills and the hospital equipment and the stone size, location, and the doctor choose different size of shaft, different size of access for the PCNL. And the access dilation, for the safety, there are also some rules for the dilation. First, before the dilation, we should confirm the wire implantation, just that the wire is inside the calyx or not. You have to make sure. Also, we can use ultrasound, can make sure the wire placement. Okay, then keep the dilation direction same as the puncture. What direction of the puncture, and then the dilation direction must be the same. And the dilation better shallow than deep. Okay, if we can't reach the calyx, we can go deeper. But at the beginning, we should avoid the deep dilation. Okay, the gradual dilation. It's for the beginners, it's safer. The gradual dilation from the small size to the larger size, gradual dilation. And then the doctor's position and the placement of our device and the lithotripsy equipments. From this picture, we can see our fusion venous system, the other surveillance screen. You have to put them the other side, and then the lithotripsy device may be at the same side of the doctors. For this patient, the left kidney PCNL, we put the device on the right side of the patient. Okay, for this is the right kidney, and our device put on the left side of the patient. Okay, before the surgery, we have to put the right place. Okay, and this is a different kind of lithotripsy equipment. Lithotripsy, like this is the ultrasound lithotripsy, like this. For this ultrasound, you have to take the larger, more than 24 F excess, larger excess, to suck the fragment like this. This is the laser, helium laser lithotripsy. This is the pneumatic lithotripsy, also very popular in clinic. This is the different kind of nephroscope. Okay, different kind of nephroscope, and then this is a needle and the dilators. Okay, then some doctors use two-step or one-step dilation. It means two-step. It means the first choose the middle one, and then the last one. Okay, not use the others. One-step dilator, just use this one. After puncture, just use this one for dilation. This is the nephrostomy tube, like multi-access, one access. The whole procedure is very successful. There is no bleeding. Maybe the doctor can choose the tubeless. No need to place the nephrostomy tube. Okay, complications and the animation video of PCNL. For the PCNL complications, there are two kinds of complications. The first one is puncture-related complications. And the first is bleeding, intraoperative or the post-operative bleeding. And if there is bleeding, the transfusion rate 1 to 35%. And why this range is so wide, so big? It's related to the surgeon's skill or experience, and operation time, preoperative anemia and the diabetes control, patient's age and the stone size, a number of tracts, something like that. So the very experienced doctor, we take the very short time. There is no anemia on diabetes, and the patient not very old, and the stone is not very big. Just do the one access, one tract. PCNL, it's much more safer. Okay. And the renal collecting system injury, it's about 7%. And the injury to adjacent tissue and organs, that this kind of complications mostly happened if we choose the upper, because we can see the spleen, 11th intercostal channel, and this is also the intercostal. Okay, up to liver or spleen, just the intercostal. Intercostal means the upper fallacy, if you choose, and the less than 1% colon injury. Okay, the most clinically the most common adjacent tissue injuries, just lungs or pleural cavity rupture. Okay. And other complications, the first one is infection. Just the sepsis or sepsis shock. This is very, very serious in complication. Also, the mortality about 0.2 is very, very almost none, very, very low, but mostly related to the infection. So it's about complications. This is the animation video. You can see.
经皮肾镜取石术适合治疗巨大肾结石、多发结石和输尿管上段结石。经皮肾镜取石手术需要很多设备，例如 B 超、气压弹道超声联合碎石机、火激光碎石机、经皮肾造瘘套装、硅胶肾造瘘管、经皮肾镜、导丝支架等等。经皮肾镜取石术。
Sorry for that.
.上段结石，经皮肾镜取石手，例如 B 超、气压弹道超声联合碎石机、火激光皮肾造瘘套装、硅胶肾造瘘管、经皮肾镜、导丝支架等等。
Microscope and the stand.
这些在手术前，
This is consumables before the surgery. We have to prepare for this.
护士都会准备好。
手术时采用全身麻醉，
And then we can take the general anesthesia or
或半身麻醉，保证不让您感到疼痛。
also.
手术时，病人采取分腿结石位。
And this is the beginning. We can take the lithotomy position.
躺在手术床上，首先膀胱镜下，再换
And under the cystoscope, we find the ureter from the bladder. We insert
侧输尿管，向上插入一支输尿管导管。
this reach to the pelvis of the kidney.
并上内注入生理盐水，以制造人工肾积
The saline water inside kidney.
水。然后，病人俯卧在手术床上，
Then take the prone position.
手术时，在 B 超引导下，一根细细的穿刺针
Under the ultrasound, we choose the target calyx. That's the middle posterior calyx, and then do the puncture.
准确刺入肾脏肾盏。
Okay.
拔出针芯后，
Okay, we can see the water up from the needle.
这时候会有尿液从针尾溢出来。然后
And then you can insert the wire
引入导丝，
in the kidney.
沿导丝实施扩张，建立不同大小的
Okay, this is the dilation. Dilation, we establish the access.
从皮肤到肾脏的通道。通过经皮肾镜观察，就可以找到结石。
Now we insert the nephroscope, find the stone, and do the laser lithotripsy.
然后利用火激光碎石机或气压弹道超声碎石机，将结石全部粉碎。
This is helium laser. Okay.
随着经皮肾镜的抽出，结石颗粒会顺着水流方向而被带出体外。
Some big fragment, we also can use the basket to take them
如
away.
有残余结石，可使用取石钳取
Or the alligator, we can take them away.
出。结石取净后，
After we remove the stone, we insert the wire to the ureter, and then pull out this catheter.
肾镜下将导丝引入膀胱，然后再沿着导丝放入
They put in this double G stent to the ureter.
输尿管支架。最后在伤口放置一支肾造瘘管。
This is a nephrostomy tube.
这样手术就结束了。
The operation is over. Okay. And then renal CT imaging analysis. For the CT, for the CT scan, there is a non-contrast CT scan is the golden standard for the kidney stone diagnosis. And then this sensitivity for detecting kidney stones up to 95%, and the specificity of CT to be 98%. And then there is a HU, it means the Hounsfield unit. This is the measurement of attenuation. Okay, in this scale, water is given the value of 0 HU. Water is 0 HU. And then the air is minus 1000 HU. And the dense bone is 1000 HU. It means the bone and the stone may be similar. And then higher than the 1000 HU, the stone is very, very firm. It's very hard to break down. And then the normally the stone is 300 to 1800 HU. Okay, the number is higher, the stone is very hard to break down. Also, according to the HU number, we can estimate the component of the stone, like uric acid stones are typically 200 to 400 HU, whereas the calcium oxalate stones are 300 to 1200 HU. And the contrast CT also sometimes we can use to use the contrast CT just to evaluate the function of the kidneys. Okay, and then enhanced contrast CT, we could also called enhanced CT. Sometimes they called contrast CT. This includes arterial phase, venous phase, and the excretory phase, and the delayed excretory phase, etc. Different phase give the doctors different information. Okay, and then for the analysis for the beginners, I want to tell you that the density and the symmetry is very important. We have to focus on these two things: the density, and the symmetry, like this. Non-contrast CT, we can observe the location of the kidney, or also the location of the stone, and then the kidney size, also the stone size, shape, numbers, and the presence of obstruction. Is there any obstruction or not? For this picture, we can see this right kidney is normal, and the left kidney is become larger, and then this density is not the same. So this shape is not the same, the size is not the same, and then the density inside the kidney is not the same. So there's not normal. Okay, this kidney left kidney, there is a big stone inside the kidney. Okay, this is the non-contrast CT. But contrast CT, we can see the enhancement of the renal cortex. Okay, this is the normal kidney. This is not normal. The cortex enhancement is not good. So the kidney also damaged. The function is also damaged. Okay. Finally, I want to share with you guys the channel planning. For the PCNL, we have to take the optimal puncture approach is the shortest path directly to the calyx. Okay, the second one is needle goes through the renal parenchyma and the calyces. Try to select the posterior calyces to enter the pelvis as much as possible. The fourth is use single channel, and if necessary, then consider the multiple channels. When establishing a channel should bypass, we should avoid adjacent organs, unnecessary injuries. Okay, if we use this fusion mode of venous, we can see very clear image like this video. Like this video, the needle, we can see the ultrasound needle that goes into the calyx, and also this is the CT scan. This is the target calyx. Their fusion, they're matched very perfectly, and then the stone location we can also see very clearly, and then also there's the other adjacent organs and the structures. We can see this fusion mode very clearly. So if we also the 3D mode, the probe location and the probe and the kidney relations and the needles, everything can be seen very clearly. Okay, this is about the PCNL puncture. This is our official account. You guys can scan this, use WeChat, scan this, our official account, follow our newest updating news also. Okay, thank you very much.